Good evening, everyone. At the outset, let me thank the organizers for inviting me to speak at this conference. Without wasting any time, I'll just begin. I'll be dealing with sudden cardiac arrest, the recent advances in management. We'll be dealing basically with the resuscitation guidelines. Okay. We will not go into the details of this. More often than not, we keep hearing these news items about patients dying of cardiac arrest on flights, footballers on the ground, in various practice matches. Most of them do succumb to the injuries. However, very few survive. This is one of the lucky survivors. Fabrice Muamba is a retired Zaire-born English soccer who suffered a cardiac arrest on the field in 2012. After intense resuscitative efforts, including 15 defibrillation shocks, before arriving at the hospital and another 30 minutes of intense resuscitation at the hospital, he survived. But not all of us are so lucky. So let's have a quick look at the resuscitation guidelines in this regard. Now we will not deal with the definition of cardiac arrest anymore. The epidemiology has already been dealt with. The cardiac electrical conduction system. Okay, the etiology of sudden cardiac arrest mainly involves ischemic heart disease in 60 to 70% of patients, structural heart disease in 10%, valvular, which includes valvular heart disease, hypertrophic myopathies, myocarditis, cardiomyopathies. It also includes primary electrical disorders in 10% patients. Non-cardiac causes attribute to 15 to 20% of sudden cardiac deaths. These are the treatable causes of cardiac deaths, the 5 H's and the 5 T's, which include hypoxia, hypovolemia, hydrogen ion acidosis, hypokalemia, hypothermia, toxins, tamponade, tension pneumothorax, pulmonary and coronary thrombosis. So this is the BLS guidelines. These arrows indicate the modifications which have taken place in various steps of the BLS guidelines. Okay, starting with the chain of survival, in 2010 we knew as the 5-link chain of survival, which has now been modified to suit both in-hospital and out-of-hospital cardiac arrest. The 5 links in the in-hospital cardiac arrest are almost the same except for the first link, which is surveillance and prevention, which has been added. In the out-of-hospital cardiac arrest, we see the chain remains the same, and a strong chain of survival improves the chances of survival and recovery for victims of cardiac arrest. Now coming to the main changes that the 2015 guidelines by AHA and ESC have recommended, the crucial links in the OHCA chain of survival are unchanged, they say, with continued emphasis on unified universal adult BLS algorithm. The adult BLS algorithm is modified a little bit. The rescuers can now activate an emergency response through a mobile phone without leaving the victim's site. It is recommended that communities with people at risk for cardiac arrest implement public access defibrillation, that is the PAD programs. The recommendations have been strengthened to encourage immediate recognition of unresponsiveness, activation of the EMS and initiation of CPR. The emphasis has increased for rapid identification of potential cardiac arrest by dispatchers, that is the dispatcher-guided CPR. The other changes include that the chest compressions are now recommended to be given before the rescue breaths. That is, it is a CAB rather than the ABC pattern. There is now a continued emphasis on the characteristics of the high-quality CPR. That means the chest has to be compressed at an adequate rate and depth, allowing for complete chest recoil after each compression, minimizing the interruptions in compression, and avoiding excessive ventilation. The recommended chest compression rate is now 100 to 120 per minute. The chest compression depth is from 5 centimeters to 6 centimeters in adults, and bystander administered naloxone is now being considered for suspected life-threatening opioid-associated emergencies. Here again we see that the community lay rescuer AED programs recommend that the PAD programs be implemented in public locations with high likelihood of witness cardiac arrest, that is in airports, casinos, sport facilities. The dispatcher or the telecommunicator identification of agonal gasp helps in emphasizes the role of that these emergency dispatchers can play in helping the lay recognizer recognize absent or abnormal breathing and cardiac arrest. There is again the emphasis on chest compression. There is a CAB pattern, and for lay rescuers it is recommended that a compression only or a hands only CPR should be done, because certain studies have found that the survival rate from adult cardiac arrest victims is the same with either compression only or with compression with both CPR with both compression and rescue breaths. The chest compression rate has now been modified to be between 100 to 120 per minute. In the guidelines update are that the upper limit of the recommended compression rate and compression depth has been set. These are based on data suggesting that excessive compression rate and depth adversely affects the outcomes. The depth is now between 2 inches to 2.4 inches, which was earlier 2 inches, and it is on the same principle. It is again reaffirmed that the rescuer should avoid leaning on the chest between the compressors and allow a full chest recoil for patients in cardiac arrest. There should be minimum interruptions in chest compressions, and now there is a certain term known as the chest compression fraction, which is a measurement of the proportion of the total resuscitation time that compressions are performed, and it should be at least 60%. The same concept applies to ventilation also, which is why ventilation in certain scenarios is delayed till 3 cycles of 200 continuous compressions with passive oxygen insufflation and airway adjuncts is done. And bystander naloxone in opioid-associated life-threatening emergencies is now in place. And in 2014, the naloxone auto-injector was approved by US FDA. And the Resuscitation Training Network has requested information about the best way to incorporate such a device into the adult BLS and training. Now, these were the guideline changes with respect to the lay rescuer. With respect to the healthcare professional, the changes are nearly the same except for a few. These recommendations allow flexibility for activation of the EMS and subsequent management for better activation of the ERS to better match the HCP's clinical setting. The trained rescuers are encouraged to simultaneously perform certain steps. This is to reduce the time to the first chest compression. The integrated teams of highly trained rescuers may use a choreographed approach instead of sequential manner as used by individual rescuers. And also, where the EMS systems have adopted bundles of care involving chest compression, the use of passive ventilation techniques may be considered. Now, these are the same guidelines as for lay rescuers. Now, the question of whether shock first or CPR first have been addressed by various studies, and there has been no difference in outcome, which is why it is still a debatable question. And the 2015 guidelines say that for fitness, adult cardiac arrest, and if an AED is immediately available, it should be used as soon as possible. The alternative techniques and the ancillary devices for CPR include the impedance threshold device, which has been used as an adjunct in certain trials. However, the routine use is still not advocated. In special settings, mechanical chest compression devices have been useful, but the routine use is also still not recommended. The use of extracorporeal CPR has been considered for selected patients in setting where a reversible cause of cardiac arrest is suspected. This is a view of the mechanical chest compression devices. They have been used suggested as a reasonable alternative in specific settings where the manual compressions may be challenging or dangerous, but manual chest compressions remain the standard of care. Just to recapitulate, upon out of hospital cardiac arrest, the first link is the early access, that is early recognition of cardiac arrest and activation of the EMS. This is followed by the second link, the early institution of early and high quality CPR. This is the chain of survival has now modified the CPR to be CAB, as in compression before assessing the airway and the breathing. The third link is early defibrillation. Whenever an AED is available, turn on the device and follow the in-computer prompts. And these are the rhythms that are normally seen. The ventricular fibrillation and ventricular tachycardia are the shockable rhythms, pulseless electrical activity, and asystole are not. We must realize that every minute lost before defibrillation reduces the chances of survival by 7 to 10%, and this is followed by advanced life support and post-arrest care. And this is a summary of the high quality CPR component for BLS providers for adult, children and infants. And a word about the Acls algorithm. The combined use of vasopressin and epinephrine offers no advantage. Therefore, to simplify the algorithm, vasopressin has been removed from adult cardiac arrest algorithm. The low end-tidal carbon dioxide EtCO2 in intubated patients after 20 minutes in association with other factors will help to determine when to terminate resuscitation. Steroids may provide some benefit. ECPR can prolong viability, so it has been suggested, and early provision of epinephrine in patients with non-shockable rhythm is advocated. Others are that the routine use of lignocaine is not advocated, and the routine use of beta blockers is also not advocated. This is a word about extracorporeal devices and invasive perfusion devices and post-cardiac arrest care. Emergency coronary angiography is recommended for all patients with ST elevation. TTM or targeted temperature management have been updated with regards to these patients. Identification and correction of hypotension is recommended, and these patients who progress to brain death or circulatory death after initial cardiac arrest should be considered as potential donors. Thank you for patient hearing.